Hello, welcome. I, I kept this picture up here. This is from last year's one that I did, but I kept this up here because there is nothing more special than the um, relationship between a girl and her cat. I'm sure all of you that are cat people or cat girls, cat persons will agree. And there is also no better relationship that a cat can have than the one that is not in my house. And it's great that this cat went to her mother's house, and that is where it stays, and that is where it will stay. Because there is outside of out of my house, the next best place for a cat is on a in a cardboard box on the side of the. What am I talking about? Anyway, let's move on. Not a cat person, as you can probably tell. Cats are wonderful. They're lovely, and we should protect them and get them out of shelters and find homes, just not mine. Okay, so we're going to talk about this week about medication assisted treatment and then also a little bit about levels of care. Okay, so we'll go through each various type of medication assisted treatment and then also talk about different levels of care that are available to people that you can help kind of direct because again, as I talked about with some of this, um, is you know someone may be coming to you wherever you're at, whether it's inpatient, outpatient, IOP, wherever you meet this person. And part of your job is going to be meeting them in that space and then sort of assessing and saying, is this the appropriate level of care for them? Okay. And that's going to be important as we have our first vignette this week. Okay. And we'll talk about that at the end of the lecture. Okay. So, medication assisted treatment, levels of care. Okay. Cool. Nice. Don't like cats. All right. Medication assisted treatment, if utilized appropriately, can be the mechanism to provide a bridge between addiction and recovery. On the other hand, if it is not managed appropriately, it can elongate an individual's recovery process and runs the risk of enabling towards future or further use. All right. So now here's the thing about medication assisted treatment. It can be really effective. It can be an absolute lifesaver. And at the same time, it can be the biggest problem in somebody's recovery process depending on how it's utilized. Okay. We'll talk more about that as it goes on because part of, we're not going to be the ones in charge of dosing somebody's medication unless you go and become a nurse practitioner, you become a medical doctor, or you become a whatever you want to become. But so there, but we can have discussions with them about what this process can be, and we are also able to meet them in that space such that they can feel secure, they can talk to us about it, and maybe we can open them up to a different way of looking at things. So, again, medication assisted treatment is phenomenal, and it is the thing that can save so many people's lives. And at the same time, it has a high potential for abuse. I don't mean that with pun intended, but okay. It has a high degree of abuse if it is not managed appropriately. And so that is going to be some of the challenge that you may face when working in this space. Okay. So we're going to focus on 5 types of medication assisted treatment and 1 neurostimulator. Okay. So the most common one that you're going to hear is methadone. I know I skipped it, but we start with methadone first, I think. But the most common one that you probably know is methadone. Another one that you probably know is Suboxone, or at least you may have some familiarity with it. Well, the generic name for that is buprenorphine naloxone. There's another medication called Subutex that is just known as buprenorphine, and we'll talk about the differences. So if you're like, what's the difference? I'm going to tell you, but I'm trying to set the stuff up. Okay. So buprenorphine and or buprenorphine naloxone, otherwise known as Subutex and Suboxone, and it can be given in several ways: sublingual, transverse abdominal, transdermal, and implantable. Okay. You also have methadone. And then, as I mentioned before, and then you also have oral and intramuscular naltrexone, otherwise known as Revia or Vivitrol. You have antabuse and you have acamprosate. okay, otherwise known as Campril. And then you also have the bridge device, which is the neurostimulator, which we'll talk about. Okay. So, how do we even assess whether or not somebody needs medication assisted treatment or could benefit from medication assisted treatment, or to even know what dose to give them? Well, that is what this is. So, this is called a COWS scale, or a clinical opiate withdrawal scale, MOO. And basically, there are some things about withdrawal that you just can't fake, specifically an opioid withdrawal. Okay. So, early on, we've got this down to a science now, but early on, when Journey Recovery Center first started, we had so many patients who would just come in and say, well, I'm feeling XYZ. Here's my medication, or, I need medication, right? Well, COWS doesn't exactly give that. All right. We'll talk about induction here in a little bit, but we had very limited induction rooms, or induction is how people get introduced to medication assisted treatment in the form of Suboxone or methadone, but I'm talking about Suboxone here. Well, in order for us to know what dose or around what dose to give them, they needed to be in withdrawal. It helped us to be the most accurate with giving them that medication. Because if you just give somebody, if they have freshly used an opiate and they come in and say, I need Suboxone, I could give you 4 milligrams of buprenorphine naloxone, and it wouldn't really do anything for you because you just use an opiate. So we needed you to go through withdrawal. At first, it was 48 hours. Well, there's not a lot of patients that can get through 48 hours. Well, then we went to 24 hours. Most could get through 24 hours. But the challenge is there were other organizations, and this is not like a us versus them kind of thing. This is just a different style. There are some that would allow patients to, come in having actively used and do their induction at that time. They would just need a few hours, or they could have just recently used and they would just dose them appropriately, or dose them as they thought to be appropriate. Now that comes with risk, because if the goal is to try to satiate somebody and have them not go out and use, then you sometimes have to just throw a ton at them. But that has a high risk, right? So the risk is let's say somebody comes in and they say, I'm going through this. You give them 16 milligrams. Maybe they only need 8. Well, now they take the 8, they sell the other 8, right? Now, of course, that's not our necessary job, but we do have to be aware of those kinds of things when we make these decisions. Okay. Also, maybe they don't need 16. Maybe they only need 8. Well, if I give you 16, then I could be overdosing you. And overdosing, not overdosing, although that could happen, I guess, sort of. But I am over prescribing you, I guess, would be the better way to put it. So how do we determine what is the most appropriate? Okay. And so we have this. So resting pulse rate. I can't fake that if I'm going through withdrawal. Sweating. One of the conditions of having opiate withdrawal, which we'll talk about when we get to the opiate setting, is that you sweat a lot, right? And then restlessness. Can I sit still, right? Most people going through opiate withdrawal just simply cannot sit still. Where's my pupil size? When you're on an opiate or any kind of depressant, your pupils get super wide because it's taking in so much light, okay? Whereas on the opposite, when you take a stimulant, your pupils go super small, okay? Pinpoint, okay? Do I have bone or joint aches? Is my nose running? That's one of the conditions of opiate withdrawal. It's just your allergies, or your nose just starts running crazy. Do I have bubble guts, right? How am I vomiting? Do I have diarrhea? What's going on? Am I tremoring? Am I shaking? Am I yawning a lot because I'm tired, but I'm also like, how much anxiety do I have? Do I have, we say goose flesh, but do I have chili bumps, right? Or the other, I guess the technical term is piloerection. And so what we do is we take these and we observe them at a particular time. Based on that score, we dose them with a particular amount, right? And so it's going to vary. Most people will start between 4 and 6, sometimes 6 and 8 milligrams, but most of them will start between 4 and 6 milligrams for the initial dose. From there, we can monitor them every 45 minutes or so and build up from there. Okay. We'll take a COWS every 45 minutes. And then usually after like an hour and a half or maybe 2 hours, 15 minutes, something like that, their third check-in, maybe we give them another 2 milligrams to see how that feels. Okay. So this is a COWS score. We do this with everyone. Okay. Everybody that would come into Journey Recovery Center and go through induction would go through a COWS score. And that would tell us what they were on. We'll talk about this when we get to buprenorphine. So keep this in mind. Okay. So, but let's start with methadone because that is the one that most of you probably have some familiarity with, or you may have actually used methadone. So it was created in Germany around World War II to address an opium shortage. Contrary to popular belief, this is an old wives' tale, had nothing to do with Hitler. There was this idea that it was Hitler that created World War II or created methadone during World War II to keep his soldiers in line, like to basically control them. But you have to think, we're talking about hundreds of thousands of casualties that are going on during the World War, and there's only so much opiate to go around. And you can only keep somebody on opiates for so long before you just run out of opiate. But they're still going through some stuff. They're still going through aches and pains, and they need to have some kind of treatment or some kind of care. Well, that's where methadone came into play. And that was really what this was. It was a synthetic opiate to mimic what somebody would receive if they received a pain pill. It's used as an analgesic to alleviate and relieve the symptoms of opiate withdrawal. Because again, when you're on opiates for so long, especially if you've got some chronic wounds from, I don't know, fighting the Americans, and getting shot, you're going to need something to help alleviate that. Okay. But the other thing that it does is it also acts as an agonist to prevent future use. So again, we talked about what an agonist does. An agonist mimics what it's supposed to, so in this case, it mimics opiates. So it makes your brain think, hey, I've got an opiate, but it really doesn't. And then the other thing is it blocks that receptor site, keeps it full to where if you were to use an opiate or you were to use like heroin, fentanyl, whatever, you really wouldn't get the same amount because it has a higher affinity. You wouldn't really feel it. Okay. Now, the thing about methadone is that it is heavily federally regulated. And not only that, but it's heavily state regulated. Each state has a different regulation. Now, Kentucky has eased up on its state regulations. There was a time in which you wouldn't be allowed to give someone a week's worth of methadone at any given time. Okay. And we don't typically hand someone for opiate use disorder methadone when they leave a hospital or when they go to treatment. We don't just go, hey, here's some methadone. It's a very heavily state regulated thing. There are 2-3 methadone clinics here in Northern Kentucky. There's a couple in Cincinnati, but here in Northern Kentucky, we got 3 New Seasons, and I don't remember the other ones because it's been forever. So I think I list them on the next one. EITC is another one. It's been forever, so I have them listed because I have a dumb brain sometimes. But there was a time in which you couldn't get like a week's worth of medication. So what would happen is that it was $15 because insurance doesn't pay for it. So $15 a day, and you would show up at like 5 o'clock in the morning because they would be open from 5 a.m. to 2 p.m. And you would just get in line. You would get your dose of methadone for the day, either in a pill or in a liquid form. And that would be, you have to do that every single day. Now imagine that every single day, $15 a day, you gotta hand that over. That's $450 a month so that you can, function basically. But Kentucky has eased its regulations a little bit. I know now they would give you for the weekend. That was fine. But people wouldn't be able to get like a week's worth of medication at a time. Now they can. Under certain circumstances, they have to be in treatment for a while and have appropriate drug screens and that kind of stuff. But it is very heavily federally regulated. There are a lot of stuff around methadone. Okay. The top picture that I'm showing you there right below my face, that's the liquid version. And then the bottom one is the tablet version. Okay. So let's talk about how it's utilized. EITC and, Northern Kentucky Med, right next to Journey Recovery Center, which we'll talk about in a second. So your initial dose is just to kind of relieve withdrawal symptoms. So that could be within 20 to 40 milligrams, depending on the patient. Okay. Your early induction is to bring the scale for methadone. Let me get a pen here. I'm going to get a pretty pen. So rainbow. So the goal with methadone is to ramp you up quickly and then slowly titrate you down. Okay. Look how pretty that is. I don't know if it feels like rainbows when they're doing it, but this is methadone over time. Okay. So, we're going to ramp you up real high, usually between 60 to 120 as listed on this chart. But in reality, it's usually about 80 to 90 to 120, right? 130. Okay. Could be more, could be less as I put on here, but we want, like, the goal is to make sure that there is that blockade there such that people don't go use once it's over, don't go use opiates or it sort of satisfies their cravings. Okay. So the thing about methadone is it does stay in your system for a long time, longer than any of the other synthetic opiates or opiates in general. Okay. Most of your opiates will be in your system for around 7 to 10 days. Suboxone can be anywhere from 10 to 14 days. Methadone can be 21 to 24 days, depending on how your metabolism is. Okay. It has a half-life of around 4 to 6 days. If you don't know what half-life is basically where the effective dose is halfway out of your system. Okay. It's actually closer to about 6 days of a half-life. Okay. So it can stay in your system for a little bit longer, which is why it's difficult for patients to really wean down over time. Okay. And when they wean down, it's usually going to be somewhere between 2 to 3 to 5 milligrams at any given time. And it's really tough to get off of, if anything, for the psychological reason. It's possible, but there is more of a psychology around it than anything because it is very difficult to get off of. Although the titration down, your symptoms don't show up as quickly as they do with the other opiates, but they are really difficult to get through because of how much it sticks in your system. Okay. So that is methadone. Cool. So let's talk about buprenorphine and or buprenorphine naloxone, otherwise known as Subutex or Suboxone. So buprenorphine was created in 1966 to assist with the withdrawal of morphine, okay, which was fine. But the problem was that people would take their buprenorphine in the morning and then be able to get high off of whatever their opiate was by the end of the day. So they would get their stuff at like 6, 7, 8 o'clock in the morning. Honestly, by about 3 or 4 in the afternoon, they could probably go use and still get high, right? So Suboxone was utilized in the 1980s in the UK to help with chronic pain, which is interesting because now, as I think I mentioned this, it's not, you don't use it for chronic pain. You cannot prescribe it for pain patients, okay? But it also helps with addiction, which is kind of how it's used today, okay? Now, we've got 2 parts, which is the buprenorphine. That's what we talked about. But then also the naloxone, and that's an opiate blocker to assist in slowing down or stopping the utilization of other opiates. It is what's called a partial agonist, meaning that it acts as an opiate agonist while simultaneously serving as an antagonist in the same receptor site. Okay. So I drew this little chart because I am a professional drawer. So if these are receptor sites, okay, these fill goalpost looking things, an opiate is going to sit in it, whatever opiate you choose. So it's a pain pill, it's heroin, fentanyl, they all do the same thing. Okay. They're going to sit nicely in this receptor site. Okay. Then a partial agonist, not a paragon, a partial agonist will act as an agonist, which again, we talked about how that mimics, like with methadone. Methadone's an agonist. So you have the 8 milligrams of buprenorphine. Now, if this was just Subutex, that's all that you would get. This other part is not there, okay? The difference between Subutex or buprenorphine and Suboxone, buprenorphine naloxone, is this 2 milligrams of naloxone that's in it. That's the oxone in Suboxone, okay? And it's ratioed in this same way. So this is, we would call this 8-2. And it goes down. You can do 4-1. Okay. So you can have 4 milligrams of buprenorphine, 1 milligram of naloxone. Actually also goes down to 2.2 and 0.5. So it scales down all the way down as you stay on this. Okay. Now we're going to talk about Vivitrol. I don't know when, but soon. That is what's called an antagonist. So if you are familiar with your English, and English literature, an antagonist is the person that pisses off the protagonist, right? So, in video game terminology, Mario from Mario Brothers is a protagonist, right? That's the main character of the story. Bowser is his antagonist, or the person that pisses him off, or like they have conflict, I guess is the formal way to say. Okay. So the person that pushes against, that rejects it, that tries to make it stop. So that's what this antagonist is, meaning it's gonna block it completely and keep it from doing what it wants to do. So if you have an antagonist here, so if somebody is on Vivitrol, or if you give someone intranasal naloxone, if they try to take an opiate, it hits it and bounces off. It doesn't even, it's a waste. Okay. And we'll talk about that when we get to naloxone, when we get to Vivitrol. Okay. So those are the two parts: buprenorphine, naloxone. Cool. Here's how it's utilized. So again, as somebody comes in, they're struggling with opiate use disorder and they show up, we ask them that they're in withdrawal. Now, I don't know, I'm sure if somebody can correct me on this. I think now it can be anywhere between 8 to 12 hours, although they ask that it's 24 hours. The way that I would phrase it to patients is the more withdrawal that you're in, the more accurate we can dose you. So the initial withdrawal, going through the preparation for Suboxone or Subutex. Day 1 induction, we've got to bring you to a level that's tolerated. All right. So what I mean by that is, let's say we start at 4 milligrams. All right. And we do a CALS and you're still struggling. Now we bump you up to 6. Check again. Still struggling. Bump you up to 8. Once again, we're still struggling. Okay. Now we get to 10 and your CALS score is sufficient to where we feel comfortable to send you home. That is what you tolerate. Now, that is where you're going to start the next day. So when you come back for day 2 induction, we don't send you home. They would send you home with some medication, right, if you need it. But then you come back and where you were at is where you're going to start when you come in for the next day. Okay. So that's what day 2 is for, depending on what somebody's CALS score is. Now from that should be where they stay. Once they get done with the second day of induction, let's say it is 12 milligrams that they're on, that's where they will stay for the initial parts of their treatment. During that, they'll receive group therapy, individual therapy, etc. But that is the space to where they can function. Okay. They're not going through withdrawal, and that's what we want to do. Okay. So most patients will be tolerated or be on a maintenance phase of anywhere between 8 and 16. Now it caps off at 16 because, again, let's do charts. Okay. Once you ramp this up and it gets to 16, the effectiveness really tapers and it kind of flattens out. Because at 16 milligrams, you've got about 98% of utilization in the body and in the brain, and that's really all that you need. Once you go above 16, there really needs to be special reason as to why that is. Now, that could be some, not all, but some chronic pain. It's not prescribed for chronic pain, but somebody could be in just a little bit of pain, and that can help them to deal with some of that pain, even though that's not the primary reason. They could be experiencing some of that, and then you could bump them up just a little bit. They could be experiencing just a really intense withdrawal symptoms. Okay. You can bump them up a little bit to 20. 20 is usually the absolute maximum that someone would prescribe. Now, and that's on very rare occasions, and those have to be considered by a board certified addictionologist. So it takes a specialist to be able to go to that level of 20 milligrams. Okay. Now, I've seen it to where we would have patients who would call us and they would say, I'm on 32 milligrams of Suboxone, which, first of all, anyway, I want to come in and continue to get treatment. And I had to tell them, we're going to go ahead and bump you down to 16. Like, you're going to get half that. And they hung up on me. Now, why would someone prescribe 32 milligrams? I don't know, because there's no clinical relevance for that. There's no evidence that that's even effective. Well, let me rephrase that. It's really effective because they're on 32 milligrams, but there's no clinical need for that. That's too much. Okay. You're over prescribing. We don't want to do that. Okay. So, long-term maintenance, patients can stay on Suboxone for a long time, and a lot of people do, right? There's a lot of maintenance there. However, the medically supervised withdrawal, when a patient decides that that's what they want to do, it's a slow taper, about 2 milligrams every 6 to 8 weeks. Okay. Depending on the patient's tolerance. Okay. So usually between 8 to 12 is kind of where a good place that people stay. And then when they start to wean down, it's gradual of about 2 milligrams at a time until they get all the way down to 0. Okay. The half-life of Suboxone is around 3 days. It can stay in your system for around 7 to 10 days, sometimes 14, depending on your metabolism. And that is one thing that we do not have a shortage of in Northern Kentucky is treatment centers that offer Suboxone. Also, primary care physicians can prescribe up to 20 patients without a waiver. I believe it was the tail end of the Trump administration that did that, or the very beginning, and segued into the very beginning of the Biden-Harris administration, that's when that became a thing. Because before you could do, there were three waivers. You could do 30 patients, you could do 100 patients, or you could do 200 patients. And you had to do a waiver in order to do those. Well, they took that waiver away to give better access to patients from their primary care doctor so that they could prescribe Suboxone. Very few of them do. Most of them will refer to Journey Recovery Center or others that are in the area. But if you're in a rural part of Kentucky and there's not any treatment centers available and someone comes in for treatment or comes in because they have an opiate problem, a doctor could prescribe them, even if they live in Podunk, Kentucky with no treatment centers for miles. Okay. So that was really the basis. It's really for rural care because there's a ton, but like in rural Kentucky, where many of you I'm sure are, that's a problem, right? Because there's not a lot of treatment centers. So the ones around Journey Recovery Center is the only one that you need to know about, I say biasedly. But Brightview is another one. Ethan Health, Groups Recover Together. There's regroups in Crestview Hills. And I think those are the main players that are in the area. So, but you really need to know Journey Recovery Center. That's all. Thanks. So there's other kinds of buprenorphine naloxone that are out there, or just buprenorphine. Okay. So there are sublingual films and tablets, right? Which are the things that you are familiar with. There are the abdominal injections. That is called Sublocade. Okay. So the way Sublocade works is they put it under your skin and it really hurts from what I hear and from what I've seen. But they would start in this quadrant or a quadrant. We'll just say this one, and they rotate clockwise or counterclockwise. Okay. All the way through. Okay. Now it can last for 28 days, or it does last for 28 days or so. For some, it lasts shorter. For some, it actually goes a little bit longer, but it just depends on metabolism. And so what'll happen is they rub like a piece of ice on your belly, and then they inject you, and then it stays in your system for that amount of time, and it gradually works itself down over time, which is great for patients because they don't have to like worry with films or tablets or taking their medication and all that stuff. It's in your system. It actually also helps with withdrawal because it just gradually wears itself out of your system, and you don't experience as intense withdrawal symptoms. I have a patient that I'm currently seeing now who's been on Sublocade for a really long time, and they just decided that they wanted to stop. It's now week 8, and they've not had any withdrawal symptoms that they can recognize. 8 weeks, and they've been on Suboxone for a long time. And then they went to the shot, and it just kind of worked itself out, right? And that's been really cool. Okay. There's also implants. So ladies, you can get, I guess men, you could do this too, but it doesn't work the same way. But ladies, you can get birth control put in your arm. Many of you probably know that. Well, the same technology is used for Suboxone. So this is something called Probufene, or Brixadi is another version of it, but they do the same thing. It's these rods right here. Okay. And we inject them. Each one of those are 2 milligrams. We inject them into your bicep, and then we do it again 6 months later on this other one. And then we take them out, and you go through in your withdrawal. It's pretty cool, right? Lasts for 6 months. Don't have to take a pill. Don't have to take nothing. It's really neat. Then there's also these transdermal patches called Butrans. I haven't seen these as much, but they are out there, and they are very effective. So all kinds of different technologies that we got at your disposal. One question that gets asked often is, can someone go from methadone to Suboxone? Absolutely. But they need to be on 30 milligrams of methadone for at least 30 days, just because of how powerful methadone is and how long it stays in your system. 30 milligrams for 30 days. Okay. And then somebody can transition. And that would be a sticking point. We would have a lot of patients who would call, potential patients that would call, and they would want to make that transition. And they're like, how much methadone are you on? Well, I'm on 120 milligrams. Okay, you need to go down to 30. Okay, you're not going to do that. All right, call us when you do. Okay. But generally, the reverse doesn't have that consideration. So there's not a level of Suboxone that you have to be on to then go to methadone. You can just switch. So let's talk about oral and intramuscular naltrexone. So this was developed in the mid 80s, and it is an opiate antagonist, which we talked about earlier, blocks the opioid receptor site. So intramuscular naltrexone, otherwise known as Vivitrol, was approved to treat alcohol use disorder in 2006. That is this thing. That is this one down here. Where's my bit? There it is. That is this one down here. Okay. And then it was approved to treat opiate use disorder in 2011. With alcohol use disorder, we can use it the same day unless your liver enzymes are inappropriate, and I'll show you what those are in a second. With opiate use disorder, you have to complete withdrawal in order to utilize it. Now, you have to be in some withdrawal. Okay. There were patients that were like, I can't wait 7 days. I have to do this. Okay. And so we would have them sign a waiver in order to do that. Now, why? Well, what happens is if there is still opiates in someone's system, Vivitrol has a higher affinity for that receptor site. So what it will do is if there's any opiate on the receptor site, it pulls that off and then attaches itself to the receptor site. Now, you may think, well, that's just one receptor. Yeah, you got a bunch of those in your brain. So imagine all of those being kicked off at the same time. You're going to go through withdrawal. In fact, that happened. I had a patient who his mom brought him to his appointments, and he had been using heroin and did not tell her. And so when he came in for his appointment to get Vivitrol, he took a naltrexone tablet in the parking lot. And within he had therapy with me first before he got his injection, because he was a little bit late on his injection. And if that's the case, we give them tablets. So he was just like a day or two late. And so he took this tablet, comes into my office within 10 minutes, checked in at 8:30, I think. By 8:40, 8:45, he was in full withdrawal, needed blankets, throw it up, shaking, crying, nose running, whole thing. That's what this does. That's why it's so dangerous and why it's so important, because somebody could go into immediate withdrawal and it could be a medical emergency. And it was. He had to stop doing therapy with me, went right into an exam room, we had him evaluated, had to go to the hospital. Because he was in full-on day 3 peak withdrawal. Okay. So we want that opiate to get out of somebody's system before giving them this medication because of how powerful it is. Okay. We would prefer closer to 10 with the Suboxone, and then closer to 14 with the methadone. Okay. It's very powerful and it works really well. Okay. There's also antabuse, otherwise known as disulfiram. And it is used mainly only to treat alcohol use disorder. So this is a tablet that somebody takes every day. Just even inhaling alcohol fumes can create nausea, right? And then full on ingestion of alcohol can lead to severe illness. Okay. So you may have heard of antabuse. If you haven't, people that have go, oh, that's the one that makes you sick. Because it does. It makes you really sick. It makes it to where using alcohol is actually not a pleasurable experience for someone that is struggling. Okay. But you got to take it every day. That's the challenge. So that's the biggest reason why we want patients to do this injection, is because let's just say I don't take my medicine. Well, after 24 hours, it's basically gone and you can go use. So if somebody is on the pill, they don't take their medicine, it doesn't work. It's the same thing here. If somebody decides they just want to go on a bender, they just don't take their medicine and they're fine and they go drink. Okay. There's another medication called acamprosate or Campril. So it will target the neurotransmitters that signal for somebody to drink more, right? Used alone, it's kind of ineffective, but if it's used alongside counseling, it can be just as effective as naltrexone. Okay. And also with any of these medicines, you want to do therapy as well. It's very, I won't say dangerous, but you want to do some kind of therapy alongside this stuff to get to the root of, why somebody continues to use, right? And how to do coping skills and all that stuff. So this is the bridge device, and this is actually pretty cool. Okay, so there's we refer to it as a neurostimulator. Okay, there are 4 cranial nerves, right, that it uses. That one, that one, that one, and then there is one. If you look at this cord, it's going behind the ear. It's back there. Okay, now this is a battery powered device. Okay, and it's got a sticky back, obviously. So basically, the way that it works is that, again, we all know about the brain, it's just electrical signals getting going all the time. So when you're going through withdrawal, there is signaling in your brain that goes, "Oh shit, we're in withdrawal." What the neurostimulator does is it senses that withdrawal and it sends a counter current coming back the other direction, going, "You're fine." And here's the thing: it sounds like science fiction. In many ways, it is, but it works. It's crazy. You have to be going through withdrawal though, and that's the challenge for many patients, is that they don't want to go through the withdrawal to get to the bridge device. Okay, so you wear it for 5 days, and then you remove it on the 6th, and physiologically, a patient is through their withdrawal. Physiologically, I'm being very specific about saying that, because psychologically they may not be, and that's where some of the challenges here come into play. Because if they're not psychologically there, then it's going to be very difficult for them to not want to use again. If they go back to the same environment, et cetera, it's very challenging for them to not want to go back and use. Okay. So other considerations to think about: is this short-term, long-term? How do we utilize it? As I mentioned before, Suboxone is not for pain management. Here's the thing though: it really helps with pain management. That's the ironic part. And that's why you have sometimes so many patients. I've had a lot of patients that would call and they would say, "I've been going to a pain clinic for however long, and I don't want to take these pain pills anymore." Great. So you want to come off of it? Well, no, I've got pain. I just want something else for my pain. Well, why Suboxone? Well, I ran out of my pain medication. I had a friend of mine give me Suboxone and it worked. Yeah, it did. But it's not for pain management. That's not how it's prescribed. Okay, not what it's for. Again, it can really help with pain management. And so you may work with patients that they've taken a Suboxone and they feel way better. Yeah, of course they do, because it's really good for pain management. But that's not how it's prescribed. It's not appropriately prescribed for that. Suboxone and benzos are not good bedfellows at all. Right? They are not good at all, because you have a depressant, which Suboxone is, and then you have basically a nerve agent, nerve relaxer, and benzos. You have a two depressants really kind of working together, and they don't mesh well together. And in fact, an addictionologist has to be the one, if you're getting both, because they're not good bedfellows. You can do it, but they're not good. You need an addictionologist to be able to prescribe both together. Okay. And then also daily dosing, because there's going to be some patients that have pain management issues. Daily dosing with methadone can be the cure. It can be not the cure, but it can be the thing that helps them. So we would have some patients that, like, they don't want to go use, but they have pain. Well, we can't. This is not for pain. Suboxone is not for pain. So maybe we have to do methadone, unfortunately. Okay. So let's segue over to levels of care. We'll run through these pretty quickly, about 10 minutes or so. Standard outpatient, intensive outpatient programming or program, that's otherwise known as IOP, partial hospitalization, PHP, short-term detox, long-term detox, or residential care. Standard outpatient, it's typically seen as community mental health care or private practice. Okay. So this is Journey Recovery Center. Where is my little pen? There's my pen. So Journey Recovery Center is up here on the 3rd floor. Then you have this whole 1st and 2nd floor that is the Life Learning Center. I'm obviously going to hype up Journey Recovery Center, even though I'm not really supposed to, but I'm going to hype it up. It's a great program and I helped to create it. So why wouldn't I promote it? They have great doctors, great case managers, great peer supports, great all around. I mean, it's phenomenal, but it's outpatient, meaning a patient comes in, they see, and then they go. Okay. That's the same thing with North Key Community Care, Northern Kentucky Counseling, etc. This is North Key. This is on Madison and Covington, right? Down the street from Journey Recovery Center. In between there is a an Asian restaurant called Kung Food. And if you've never gone to Kung Food in Covington, do yourself a favor, go to Kung Food in Covington. If you like Asian food, it's the best Asian food you'll ever have. It's phenomenal. So this can include your outpatient stuff, includes individual counseling, group counseling, targeted case management, peer support, and medication consultations, depending on if they have that. May or may not have a standard set term of treatment. Okay. And this is what we consider the least restrictive form of treatment. Okay. This is the least restrictive form of treatment. Intensive outpatient programming or programming depends on how you define it. Okay. So there's some programs that do a whole lot of counseling services and they call that IOP, right? But by the letter of the law, which in our terminology is the Center for Medicare Services, although Medicaid's in there too, that's state, but Medicare is federal, and that's where a lot of our stuff, when we say CMS or you hear that word, Center for Medicare Services, IOP is defined as 9 hours a week of group, okay? That can be 2 hours, 5 days a week, or it can be 3 hours for 3 days a week. There are some programs that are private pay or they don't take insurance, or they get grants and stuff for their program, that they'll throw a ton of counseling stuff and they'll say IOP, that's IOP. But that's not the letter. I mean, it can be because it's intensive and it's outpatient, excuse me. But that's not how we would consider IOP, what we as therapists see as being IOP. Okay. So, or how the Center for Medicare Services sees as IOP. So 2 hours a day, 5 days a week. I know that's 10 hours, but you got to get 9 hours a week, or 3 hours a day for 3 days a week. Typically will last for 8 to 12 weeks, though you can go longer. And it usually has a standardized curriculum. So at Journey Recovery Center, it may change now, but when I was there, we had 24 modules that someone would go through. Once they went through all of them, then we would consider graduated from IOP. Okay. Partial hospitalization. So this is completed at the hospital level, although it can be modified in an outpatient type level, depending on how you want to do it. Typically, you're engaging for anywhere between 6, 7, 8 hours a day, and there's a variety of services and treatment, but you do get to leave at the end of the day. A common one is to check in at like 9 o'clock, and then you check out at 3:30. So you go to the hospital, you stay there, do a series of stuff, and then you get to go. Typically, this will last 2 to 4 weeks, although it can extend for longer periods. So this is just example. Okay. So, if it's just, so for this one, they have 2 different PHPs. They've got a core mental health and then a dual diagnosis. When we say dual diagnosis, we mean substance use and mental health. All right. So from 8 to 10, vitals and a meditation group. 10 to 12, we're doing a weekend process. Okay. 12 to 2, we're doing some psychoeducation. We're talking about acceptance. 2 to 3:30, got this. 3, and so on and so forth until the end, and then they get to go home. Okay. So this is a sample schedule. So you can see there's a lot of stuff here. We've got, let's just look at Monday, right? So we've got a med check. We've got a weekend group, got processing, psychoeducation. That could be a lecture that somebody attends. Okay. Sound therapy and breath work. Again, that's group stuff. Individual TMS or transmagnetic stimulation. That's, these little, they look like headphones, but they put them on your temples basically, and they shoot little like magnets. They work like magnets, and it helps, and it's really good. It's really good for depression. Usually it takes about 20 to 30 sessions for it to get your maximum efficacy. Usually about 24, but it's really, really good. We do it here at St. Elizabeth. I say here, I'm at NKU. I work for St. Elizabeth. They do it at St. Elizabeth. Okay. Here's another group. Then we go to gym, right? And then there's a NAMI meeting or a 12-step meeting, depending on what you want to do. Okay. Then here's some art therapy, trauma therapy. Is there family stuff in here somewhere? Family style, right? Family night, bingo, right there. Family night. So you got a whole lot of different things going on all at the same time, but it's all connected here. Okay. For PHP. Short-term withdrawal. This is withdrawal. The name that we like to say is withdrawal management, formerly known as detox. Can be anywhere from 3 to 14 days, depending on the substance. Okay. Typically, benzos and alcohol will take 3 to 5 to 6 days. Then you've got your opiates that'll be in the 6 to 14 day range. 99.9% are completed in a facility with medical staff available. Medications may or may not be provided. So for alcohol or benzo detox, you're probably going to use Ativan to help with seizure risk. But then an opiate detox, you could do a very brief methadone taper or a Suboxone taper, depending on what you're doing. Focus is on the stabilization of the patient, usually 28 days at the most. Okay. Because that's what insurance says. And we work for the insurance company, right? Don't we, kids? Then you have long-term residential care, otherwise known as rehab. And this can be anywhere from 30 to 60 days. Okay. Some can extend care for a year, depending on the severity and if you got the cash. But what it's going to do is there'll be daily groups, daily milieu, psychiatric consultations, meals, rec activities, counseling, recovery meetings. Basically, patients move in and they just live there. This is the most restrictive form of treatment because you go here and you don't leave. Okay. This is one that I went to in southeastern Indiana. It's called Wooded Glen. They took like a convention center where like businesses would go and have conferences for like team building, and they turned it into a recovery center. And I'll be straight with you, it was really nice. There was a dock, like a bridge dock kind of thing on this water here. And when I went and visited it, they were doing a 12-step meeting on that dock, and it was just like so serene and peaceful because it was like October when I went, and the leaves had fallen, and it was just like a painting. It was so beautiful. And the food smelled amazing, and you get beds and you get all this stuff, and they had a rec center. They had basketball outside. I mean, it was really, really nice. And this was a place that people go and they stay and they find their recovery. So this is considered the most restrictive form of treatment. Okay. That's long-term residential. Cool. So vignette number 1, that's this week. The diagnosis will be given to you, so you don't have to worry about a diagnosis, but it will be up to you to use your resources so that you can tell me the level of severity and why. I'm not going to spell it out for you, but you have all the information and resources that you will need. Okay. You'll also be given a template. So I want you to do it on the paper that I give you. You can type it and mail it and send it back in on Canvas. You can write stuff out, whatever you need to do. I want you to use this template that I provide for you. Then you're going to assign me a level of care. Okay. Remember, as I talked to you before, what can you clinically justify? Okay. That's all that I'm looking for. Of course, there are going to be some things that are like, okay, I get that. Like if you say he needs to go to visit space aliens on the moon, no, but whatever you feel like you can clinically justify on what's on the paper, cool. Also remember, no pressure. Okay. I'm here. This is a growing thing. This is where you're going to start. The next one, we're going to build on that. Okay. So by the time that we get to the end, ideally you will have the ability to develop this full treatment plan that you can say, okay, here's a diagnosis based on what I'm seeing. There in the future, there will be a vignette where you actually have to like form a diagnosis and what it looks like, but we're not there yet. And so you'll get the diagnosis, but then you're going to give me everything else around it. You have the resources, you have the slides, you have the lectures. Go back and use those because those will really help you. Okay. I think you all will do very well. And I'm not really that hard of a grader unless you're just way off. So there you go. As always, Canadian geese are definitive proof that evil exists. Live mahalo. I'll see you next time. Okay. Bye.